Welcome to SDSF Live. Please let us know where you're logging on from. I'm Nicole Shin from Houston, Texas. I'm actually a little giddy for tonight's show. He is one of our community's favorites. Somehow he makes talking about poo and spew so understandable and entertaining. He's also super passionate and smart about SDS. Our giveaway this evening is brilliant. Michelle thought of it, and it couldn't be any more perfect. I think Michelle did a live reading about it earlier this week. Michelle could not be with us tonight, but we have Orva stepping in. You know, Orva normally is behind the scenes, but she's also wonderful as a host. I think I had to miss 2 shows so far. My son was in the hospital. We also had a hurricane. We do not have a hurricane today. I think another one's heading to us this week. So you could win the book Everyone Poops, which is an awesome book. Everyone should own it. By liking, commenting, sharing, starting a watch party, interacting with the show in any way. If you're new to STS, this is a great show to start with. Generally, the pancreatic insufficiency is one of the first and most persistent issues SDS patients face. So we're going to start off with a poll question. Have you or your child outgrown pancreatic insufficiency? Hi, Orva. So we thought about starting a poll with, does your child or you yourself have PI? But I feel like a lot of us do. So I think a better question would be, have you outgrown it? Because by school age, I believe 50% may outgrow it. So you'll see if the answer is yes, thumbs up. If no, a heart. And then never had it, a surprise face.
Like, I know for RJ, he has it, but we are weaning off of enzymes. So that's interesting for us because we're trying to.
No way.
Yeah.
I will say I'm not really jealous for a lot of things for SDS, but I am super jealous of the people that get to wean off of the enzymes.
Yeah, we could not figure out the enzymes, so I'm really, really glad that he's finally weaning.
That's exciting. I'm so happy for you guys. That's really exciting. So this show is going to be part of our camp series. So Dr. Grover is going to share his screen, and then after his presentation, we're going to take questions. So welcome, Dr. Grover. We're very excited to have him. Hi, Dr. Grover.
Hi, guys. Can
Most
everyone
of
hear
y'all
me?
know him. He works with Dr. S at Boston Children's. He's been at camp. He's been at SDS Day. So a lot of us know him. For those of you that don't know him, he's one of our favorites, like I said. He's also on the SDSF Medical Advisory Board. So thank you, Dr. Grover. We're going to throw the floor over to you now.
Perfect. Perfect. Well, that picture you had of me was just atrocious. So thank you for that. I don't even know where that was from, and wherever it was from, it needs to be removed. But I am going to try and do some technical things right now as I get my screen going. Trust me, we did rehearse this and practice this. I guess one of the first things, Orva, is if you don't mind sending me that link.
Yes, I'm working on it right now.
Perfect. And then I will start sharing my screen. And we'll have a great chat. Just atrocious, so thank you for that. I don't even know where that was from, and wherever it was from, it.
Oh my goodness.
That's never happened.
Just atrocious, so thank you for that. I don't even know where that was from, and wherever it was from.
You guys there?
Yes.
I am here.
Okay, I don't know what just happened. That was interesting.
It's 2020 and new things happen every show.
Well, if you guys said this is being recorded, it's no problem. I can actually get started, and I can always send the link later.
It's not letting me post it, but I'm sending it to your email right now.
Oh, thanks. Well, why don't we get started? I know people are here, and I'd love to get started and introduce myself. So I guess for those of you who haven't met me before, it's a pleasure to be here today. My name is Amit Grover, and I'm one of the pediatric gastroenterologists at Boston Children's Hospital. My area of interest has always been pancreatic disease and pancreatic disorders, which is what allowed me to kind of find my way into the world of Schwachman. And before anything, I really want to thank the foundation for inviting me to speak. Many of you have heard a version of this talk before. I have given this at camp, but I've also made some tweaks and changes, and I tried to make some updates for it. So it's similar, and for those who have heard this before, it should be a nice refresher. And for those who are now seeing it for the first time, I hope it's informative. As I mentioned, hopefully we'll have some time for some questions after. And I guess we'll get started. Can everyone see the presentation? Orva, Nicole, can you guys see that?
Yeah.
Yep, you're good to go.
Perfect. So, perfect. We got our first slide. So I've entitled today's talk, The GI Manifestations and Complications in Shwachman-Diamond Syndrome, Part 1. And I call it Part 1 because I think we're going to be lucky enough in the upcoming weeks to also have some members of our pancreas team at Boston Children's, my spectacular dietitian, Catherine Truscott, who should give a small little talk, and the hepatologist that I work with, Dr. Andrew Wehrman, who is also one of our faculty here, who help in this patient population to also give a short review. And so they will be coming up in parts 2 and 3 in the upcoming weeks. But I'll get started today on a general overview of the role of the GI tract in Schwachman. So, as you all know, SDS is a very broad but multi-system disease, which in its nature requires a multidisciplinary approach. This involves hematology, oncology, GI, liver docs, hepatology, nutrition, endocrinology, neurology, feeding specialists, geneticists. And while all these providers who can make up so much and take up so much of your time in our really hospital base, I always like to remind families and patients that I get the fact that we are only just a very, very small portion of your child and your family's care. And so much happens outside of this. We are a snippet in time. And there's so much more that happens outside of the hospital when we think about things like school and involvement with teachers and classmates, and is your child on a learning plan, and how do we manage childcare or extracurricular activities? Do children with Schwachman have to take separate precautions when they're on vacation and when they're traveling? How do other family members and siblings deal with this? What about daycare and social work and early intervention and dentistry? The point of what I'm trying to say with this slide here is that I can sit here and I can talk for hours on poo and spew and butts and guts, which all my patients love to hear about. But, it's important to realize that there are so many other aspects to your care that are outside of the hospital. And if you don't think that your GI doctors or your specialists don't realize that, I want to assure you that we do. And we realize that, and we're aware of it, and we're thinking about that as well. So I want you to know that on our end, we do look at this as more of a holistic approach in addition to the multidisciplinary approach. And now that I've said that, let's talk about what excites me, obviously, the GI tract. These are the organs that, encompass my space. We have here, let me see if I can turn on this laser pointer. Perfect. So here we have our lovely GI tract. This is what I look like in my younger years, clearly. But the main organs that I worry about and think about are obviously the pancreas here. We have our GI tract with our small intestine here, and of course the liver. And one of the things I want to say that while all these organ systems have different roles, they don't work in isolation. And when there's issues with one, there are downstream effects that affect so many other organ systems and body parts. So it's not like we can think of each of these in complete isolation, but they all come together and work in harmony. And when we do have issues in one area, it affects the others. So starting off first, just as a quick review for those who don't know or who just need that refresher, the pancreas is a great organ. The pancreas is the organ that's responsible for making enzymes. And these are the enzymes which digest our fats that we eat, our carbohydrates, and our proteins. And various enzymes, either known as lipases, or amylases, or trypsins, help in digesting the food from mouth to intestine. It has to be broken down. And so these enzymes are very important to the phase of nutrition that we call digestion, which has to be separated from absorption. And absorption occurs in the intestine. So after we've digested our food, which is one phase, we have to remember that all those new molecules now are absorbed across the intestinal wall. And in Schwachman, the cells that make these enzymes in the pancreas, called acinar cells, are typically full of fat. So less enzymes are made. And when we can't digest our essential nutrients, our essential fats that we need, our carbohydrates, we fall into this category of maldigestion. And then how do we measure if we're maldigesting, or how do we measure our pancreas function? Well, we can measure it through a multitude of ways. There are some blood tests and there are some stool tests. And when you're in a different age group, different blood tests have different meanings. And some of the blood tests you may have come across or seen are one called the serum trypsinogen, another one is called a lipase or an isoamylase. But it's important to remember that some of these tests are going to be skewed depending on the age of the child when these tests were drawn, because not all of these enzymes have reached full maturity. It's also important to remember that stool tests, like the commonly used fecal elastase, can also have false negatives and false positive values and can be skewed in itself. And just like any test that we have in medicine, there's going to be a utility of it that you have to keep in mind that sometimes may not always be correct. And so sometimes we take the conglomerate of these tests together to give us the sense of how our pancreas is functioning. And in those cases where, you're not making enough enzymes, perhaps in the setting of Schwachman or other diseases, we term this being pancreas insufficient, or exocrine pancreatic insufficiency, EPI. The good thing is we can give you enzymes to supplement this, and that's what PERT is, pancreatic enzyme replacement therapy. And there are multiple types of PERT available out there. One's called Creon, Pancrease, Viocase. They vary on their formulation. We typically dose enzymes based on the lipase unit. So in Creon, for example, here, this is a 12,000 unit capsule. A newer kit on the market is Relizorb. This is an actual cartridge that for kids who are dependent on G-tube feeds, for example, or NG feeds, you can just put it in line with the formula into the intestine, and that way it digests it through there. So that's kind of Pancreas 101. Next, we think about our small intestine. And so the small intestine is responsible for that absorptive phase I was talking about. After we've broken down our food and our products through using our enzymes in the digestive phase, now we have to absorb these fats and carbohydrates and protein. And while pancreatic enzymes are essential to digestion, absorption really occurs in the intestine. And when food can't be absorbed because of intestinal issues, then it comes out in the stool as either diarrhea or oily stools, which your doctor may refer to as steatorrhea. If food can't be absorbed, and growing infants and children can't get their essential nutrition, their vitamins, their minerals needed for normal growth, we term that malabsorption. Continuing on this, poor absorption can occur when the intestinal surface is inflamed or damaged. Some examples that you may have heard about are things like celiac disease, where the surface of our intestine has lost its absorptive capability. Patients who have something called inflammatory bowel disease and autoimmune disease leads to inflammation of our small bowel, and Crohn's disease, for example, and that impairs our ability to absorb food. various infections of the GI tract cause the lining of the GI tract to want to shed its surface to help expel the infection, and that impairs absorption. Toxins, radiation exposure in kids who are undergoing chemotherapy or radiotherapy, for example, can affect the absorptive capabilities of the intestine. So it's a pretty robust organ, but it's liable to be insulted in many ways. And when we damage that surface, it impairs the absorptive process. And I guess that poses the question: what do we know about the intestine in patients with Schwachman? Well, it has been studied. There was a study that came out in 2010, so a while ago, from the Pediatric Hospital, Great Ormond Street in the United Kingdom, where they actually looked at patients with Schwachman who underwent an endoscopy and/or colonoscopy. And more than 50% of these patients who underwent a scope had abnormalities based on the pathology of the samples that were taken and reviewed under a microscope. What they noted was some flattening or some inflammation or even enteropathy. So, enteropathy. And so, what do I mean by flattening, for example? When we think about the normal intestine, it's like a shag carpet. It's like, seaweed lining the bottom of an ocean, and all these like finger-like projections that come up are a surface area that you can absorb your nutrition. When you have flattening, these have flattened. So there isn't that surface area. If you can see in this picture, you can see all these like little finger-like projections, and that's a normal healthy mucosa. But when it's flattened, it looks flat, it looks cracked, it almost looks like it's a dry desert as opposed to a lush forest. And that's usually what I try and use it to describe to my patients who have flattening in the intestine. But since that study in 2010, there really hasn't been any new data. And so one of the things that we started doing was we were studying the biopsy reports of patients in our registry. And not everyone in the registry has undergone a scope, but what we were able to see that in looking at the data from the SDS registry thus far, that about 20% of patients underwent some sort of endoscopic evaluation, either an upper endoscopy or colonoscopy. But what was really interesting, and based on the biopsy results, was that about 40% of them had some sign of inflammation in the GI tract. And this could have ranged from inflammation in the esophagus, what we call esophagitis, inflammation in the stomach called gastritis, or inflammation in the colon or colitis. One individual actually had findings that were suspicious for inflammatory bowel disease. What we're trying to go back and look more at in the registry now is to understand why were these colonoscopies or endoscopies done. But it does prompt the question is that while we initially may have thought that Schwachman may have been an involvement of just the pancreas or issues to do with the intestine, I'm now beginning to think that this is an and that this is issues related here and here. So those were two of kind of our bigger organs that we do have a little bit of information on, but that poses the question, what about the liver? And this is the hot organ. This is the organ that some would consider, the black box and that we don't know much about. And I'm really happy that I have a colleague here at Children's, Dr. Andrew Wehrman, who's one of our hepatologists in the field of GI. People are often divided, as we call lumen or liver, and the lumen docs kind of take care of intestinal issues, but the liver docs are, these group of docs who are exceptionally smart, and they know everything about the functions of the liver. And it's because the liver is so important. The liver has so many functions. I often tell my trainees and residents and fellows on the floor that your liver is your best friend because your liver is always working in the background. Your liver is the one who allows you to take medicines or eat all the junk food that you want to have. It allows you to detox after you have to take certain medicines or be on different drug therapies. The liver has important roles in so many aspects of our homeostasis. It's essential in metabolism and energy balance. It has roles in storing glycogen or making glucose. So it has important roles in energy synthesis of carbohydrates. It can synthesize fatty acids, which are so important. It allows us to make various proteins and amino acids that we need, important clotting factors. It has a role in hormones and intra gastrointestinal communication. as I mentioned above, it detoxifies anything that we eat, or if you're taking certain medications, they all have to go through the liver. It has to metabolize all these things. It makes bile, which, believe it or not, is so important in digestion of fats, and it has so many important roles. And the thing that I also found very interesting, that I joke about with your hematologist and oncologist, is that even in utero, the liver makes blood. So I mean, if you want to think about it, your GI docs are also your hematologists in some regard, but you don't want to ask us any hematologic questions. I trust me, you don't want me managing that. But the point is, the liver is really important, and it has so many important functions. And when we think about the liver and SDS, how is it typically manifested? Well, children and infants may often have an enlarged liver, or what we call abnormal liver tests. Our current guidelines recommend that you should follow levels as indicated, and these are things that we're trying to change as we're trying to standardize our approach to diagnosis and following these. But the hard part is that most patients with elevated liver tests really have no symptoms to report. And I think the unfortunate thing, which is what we're hoping to work on, is that we don't really know the long-term outcomes, because unfortunately we haven't studied the liver prospectively in these patients. There was a case report that came out last year that talked about cirrhosis complicating Shwachman-Diamond syndrome, and I don't think we have enough information thus far to say that all patients with Shwachman-Diamond syndrome are at risk for cirrhosis. But this was a single case report where a young child or a young infant presented at about 16 months with failure to thrive, one of the more common presentations for Shwachman. And their genetic workup after being seen by a gastroenterologist had shown that they had the mutation for Shwachman, but they had this persistent liver inflammation, or transaminitis, but it was mild. But then they noticed that at about 3 years of age, their spleen was a little bit bigger, their liver was a little bit bigger, and they took a biopsy, and it showed that there were some stages of early scarring. When this happens, when you have this irreversible scarring, that can lead to downstream effects in the liver. And this patient ultimately needed to have their spleen removed. They did present subsequently with evidence of high pressures in the liver, or what we call portal hypertension, and then were needing to be evaluated for a subsequent transplant. I want to stress, though, that this was one case report, and there are few instances where this occur, but I don't want to say that this is the norm. Interestingly enough, the liver has a great ability to heal, and that the data has shown that most often a lot of the inflammation that we see in the liver tends to improve over time. But that doesn't mean we ignore the liver. I think this is an organ that we have to truly respect and keep a close eye on, because we don't want to be caught in that situation where we have uncontrolled inflammation. So some of the liver complications, as I mentioned, you can have a large liver that's felt, but this isn't unique to Shwachman. There are other reasons and other diseases that have fatty infiltration or a large liver. So I don't want you to think that this is just a Shwachman related thing. Your hepatologist will be instrumental in helping you realize if it is or if it isn't. And the inflammation, or the transaminitis, is pretty non-specific. It can be due to lots of reasons. If you have a cold, for example, or a virus or a mono, your liver numbers can be elevated. So when you have inflammation of the liver, we also can have impaired bile flow, or what we call cholestasis, and these are things that can have further downstream effects. But as I mentioned, the liver has a great ability to heal and regenerate itself, but we want to try and prevent this continued inflammation and scarring. If not, when we get this irreversible scarring, that's when we get to that stage called cirrhosis. And cirrhosis can have major downstream complications, things like jaundice or itching. You could have problems with bruising and bleeding. So all those major functions that the liver has, when it's scarred down, it can really lead to some worsening effects. You could have weight loss. You can have an increased risk for infections or even GI bleeds. And it does sound a little bit scary, but I think having that understanding and recognition of this is important. And that's why we involve hepatologists, and we should be involving hepatologists. The vast majority of patients won't experience any of this. However, I think it's important for us to realize that the liver is such an important organ in an area that we need to focus on, not only clinically, but also in terms of our clinical research. One of the newer things that many centers are using, and I want to just briefly touch upon, and I know Dr. Wehrman can talk to you more about this when you chat to him, is a non-invasive early marker to look at the liver. This is called a fiber scan, where they take an ultrasound probe and they put it on the liver here, and it injects a sound wave, and it's able to measure the stiffness of the liver. And so liver that's scarred down tends to be a little bit stiffer, and it can measure how stiff it is. And this is a great modality that's been validated to early detect changes or fibrosis before the cirrhosis stage. We actually just recently submitted an abstract for our GI conference where we looked at a cohort of about 8 patients at Children's that I follow that have had the fiber scan. And we saw that 4 of them, or about 50%, had some abnormal fiber scan results. But they had normal ALT. So these are people that we're going to continue to follow and see if we see any changes. The beauty of the fiber scan is that it means we don't necessarily have to stick a needle in every liver to get biopsies, which can be tough for little kids. So I'll stop there in regards to the liver. And it's something that I think is an area that we're going to see and learn a whole lot more about in the upcoming years. The next thing I wanted to talk about, which is how most kids present in Schwachman, is growth. And I put parentheses growth failure because this is usually how it first presents to ourselves. So growth failure, or some of you may have heard, it's also known as failure to thrive, is really used to describe children who just demonstrate inadequate physical growth or who are unable to maintain the expected rate of growth over time. It's often defined when children are less than third or their fifth percentile on more than one occasion, or if their growth drops and they cross 2 major percentiles over a period of time. You have to remember that in pediatrics is a field of measurement. It's not just one snapshot in time. And that's why we get our growth and our height and our weight and our head circumference at all our physicals from birth up and through until adolescence, because we assess this longitudinally. And often growth failure or failure to thrive is identified in the first 3 weeks, or sorry, the first 3 years. And when we think about it, there are different terms you may come across. You may have heard of something called stunting, when the body weight is proportional to the length, but the patient is just small for age, versus wasting, when the body weight is actually very low relative to the length. We like to maintain some degree of proportionality. And there are lots of risk factors for growth failure. The inability to maintain or have the adequate calories, which you may see in maldigestion or malabsorption. Other organic causes could be major illnesses, or do we think about inadequate absorption? As I mentioned, the celiac disease, or their kidney disease, or inflammation. But then there are also some patients who have a really high metabolic rate, such as hyperthyroidism or cardiac disease. So there are lots of things that come into play when we think about the metabolic demands and the nutritional needs of a child, which is why it's important to have a dietitian on board. And, Catherine will talk to you guys next week. In Schwachman, impaired growth is often our very first sign, and the average birth weight is about the 25th percentile. So they're typically smaller babies, and after age 1, most children remain below the 3rd percentile. The great thing is once we've identified this and we start them on pancreatic enzyme replacement therapy, the growth velocity, so the rate of change, tends to normalize. But it's more than just thinking about nutrition and enzymes. There are lots of reasons where I think growth is impaired, and this is where having a dietitian is really important. You have to think about feeding difficulties. Some of these kids have poor dentition. If they're not digesting, then we supplement with enzymes, or if they have signs of inflammation that related to absorption. When kids aren't getting their essential nutrients, their fat soluble vitamins, or their minerals needed for growth, that's going to impair things. We talked about how liver function is important in essential protein. So if their liver is uncontrollably inflamed, then that can lead to impaired growth. There are endocrine abnormalities and there are behavioral issues too. And I want to stress that this isn't unique just to Schwachman. Kids are picky eaters. Kids have other things going on in life and stressors. You may have kids who have oral aversions or feeding issues or textural issues. You put all these things overlaid on cases of where malabsorption or maldigestion, and it adds up. And that's where we start to see the culmination with failure to thrive. For the most part, you've all seen these. These are growth curves. You have WHO growth curves and CDC growth curves. But what we found was that over time, kids with Schwachman were just always hovering around the bottom here. And they looked like they were continually failing. Last year, what was really great was that the Italian group actually came out with specific Schwachman growth curves to really try and understand how the growth is seen in our population. Now, whether or not this has been validated in the US cohort yet, this is something that we're looking at a bit further, but it's really starting to illustrate that not everything that applies to every other child is going to apply to our patients with Schwachman. But it's great that these growth curves really represent the first set of normative curves for children with Schwachman-Diamond syndrome from 0 to 8. And I think it's important that we consider or think about using these. But when we think back more about malabsorption and its effects in nutrition, there are so many essential fat soluble vitamins and nutrients that Catherine will talk to you about next week that are important. And I'll just briefly mention that we always want to look at things like vitamin A. And these are some of the issues that can occur when you have low levels of these vitamins and these fat soluble vitamins, vitamin D, vitamin E, vitamin K, so our ADEX that we typically think about. Then we have essential fatty acids, which are really important for neurologic development, or even these micronutrients, which the literature has shown us tends to be a little bit low. So these are all things that we test for and we look for in our patients. I think going forward, the questions that remain in terms of guts and growth are there other reasons for malabsorption? And that's why we're looking at what some of these biopsies have shown. If we replete early enough, do we lessen the long-term risks? Is it worthwhile even considering supplementation on all these patients? And I think these are the questions that we're hoping to study and look forward as we go, as we progress with new guidelines and as we standardize our management. I've talked about a lot of the complications that come up, and I guess the point I want to just take a minute here is that I'm not here to scare or worry you, and I kind of want to take a quick second for you just to think about something that makes you happy. If it's ice cream, or maybe you're someone who likes unicorns or pets. I mean, that's our puppy that we have. You might be someone who needs a good beach vacation, or like my wife loves a good romantic comedy. Maybe a sunset is your thing that makes you happy, or I guess your favorite football player who doesn't really play in New England anymore. So I guess we shouldn't talk about it. So I guess I would just replace him with, your favorite gastroenterologist. The point is, we are thinking about all these things, and we want you to know that we're thinking about them as well. And that, which is my segue into kind of my approach to therapy. And I started because this is our approach. It may not be everyone's approach, but I think it's important when you're thinking about the GI care for your children or your families, is you want to try and find a GI provider who actually sees more than one or two Schwachman patients, or at least has some experience with pancreatic and or liver disease. It's such a rare disease, and because a GI doc in their career might have one Schwachman patient, there's really no consistent approach to their care and management. And I think that's where we've seen different ways to do things over time. But if you have someone who sees a good cohort, then at least you can start noticing things and looking for things. As I mentioned in my very first slide, a multidisciplinary approach is important here. And this involves not only your gastroenterologist, your hepatologist, your nutritionist, but working closely with a hematologist, working closely with a social worker and psychologist, or a feeding specialist if need be. When we think about our specific therapies, the first thing I often say when I see a new patient is, let's make sure we have the right diagnosis. There are lots of causes for exocrine insufficiency and poor growth. Could this be cystic fibrosis? Could this patient have chronic pancreatitis or any other intestinal involvement like celiac disease or inflammatory bowel disease? Is there any relevant family history? I like to get a measure of pancreatic function early on to set my baseline. Like Nicole had mentioned at the beginning, 50% of patients actually have normal function after a year. And it's important to realize that age relevant testing should be used. As I mentioned, the fecal elastase is most often used, but can be falsely normal. It can be falsely abnormal. So there are other tests that you have to look at in conjunction. I think establishing a baseline of liver function or measures of fibrosis, standard liver tests, looking at your albumin or your clotting factors. Consider that FibroScan analysis if it's available at your institution. Working closely with your dietitian to get a sense of your baseline fat soluble vitamin levels, your AD and EK, your trace elements, establish nutritional practices and see if they how their growth is on perhaps the Schwachman curves or if they're meeting nutritional needs and meeting their nutritional requirements. If there are feeding issues, consider help from other subspecialties. Do you need a feeding therapist? Do we have aversions? Are they a picky eater for whatever reason? Do they have poor dentition and need to see an oral surgeon? If there are behavioral issues, what's going on at school? Are they being bullied? Are there issues at home? Are there stressors at home? Would the benefit of, a psychosocial counselor be there? I think it's important to think about imaging and get a sense or a baseline of what our pancreas looks like. And we're trying to think about new modalities to study the pancreas in these patients. When we think about our enzyme supplementation, our PERT, and I know Catherine will talk a bit more about this, what formulation is best? Do you want coated or non-coated enzymes? Are you feeding by the mouth? Do you have a tube in place? What happens if you're not seeing the weight gain? How do you adjust the dose? Do you need to be on extra multivitamins or minerals? Ask yourself, are you seeing an improvement? Are the enzymes being dosed correctly? Are they stored correctly? Have they expired? Sometimes going on an acid medicine in conjunction by a GI doctor can help. But if it isn't the pancreas and you have normal function, is there something else going on in the intestine? Maybe it's that absorptive phase. Would you benefit from an endoscopy or a colonoscopy? Are there new symptoms? Pain, choking with food, gas or distension? Is there blood in the stool or jaundice? You have to remember that children with Schwachman are still children and they're at risk for developing other common GI issues. And so that prompts the question, if it's not Schwachman, then what? And I think this is where your GI provider should always question if a symptom may be related to SDS, but it may not be. And it's important to think about those things as well. Other common GI issues, abdominal pain, irritable bowel syndrome, constipation, reflux, lactose intolerance. Gosh, I can't tell you how many people have lactose intolerance in the population. Less common issues that we think about are, could this be bacterial overgrowth or eosinophilic disease? As I mentioned, IBD or problems with motility. I've starred these two here because, this is what the bread and butter of a pediatric gastroenterologist is. We see a lot of kids with belly pain. Almost 40% of kids have complaints of belly pain weekly or more frequently. 50% of kids have seen a medical provider for belly pain, and 3% of them have seen a GI specialist. I think it's important to recognize red flag symptoms such as weight loss or blood in the vomit or the stool or persistent pain or vomiting or even a unique family history. Constipation is a picture of me as a child. It's seen very commonly in kids and adults, and it can present in many different ways. It can present with infrequent stools. And younger children, they can have a loss of an appetite or bloating. You might see smears or bits of stool in the diaper or underwear. And we have lots of therapies for it. But the point of all this I'm trying to help realize is that, there are other things going on as well. And working with your GI doctor is important to think about these other things. I have patients who are on enzymes and are also constipated, so we think about a bowel regimen for them. I see that I'm coming close to time here, and I do want to leave at least 5 minutes for some questions. So that brings me to what's next. Well, I think I've spoken a lot about the complications, but I really want to stress that I want you to trust your team. We're thinking about you, and we're looking out for you. And we're thinking about all these things. And I think the key is team here and having a multidisciplinary team. I think going forward, prospective studies examining the GI symptoms in patients in Schwachman and working collaboratively with GI specialists and pancreatic disease across the country, even the globe, are important. And I'm happy to work with any local doc or any GI doc that you see. Please have them reach out to me. Of course, I'm happy to be as helpful as I can. Further studies in the intestines and specifically the liver, I think are important, as we're seeing this is more than just a disease of the pancreas, which has always been taught. I think working with the foundation and the registry, we're now finally establishing a standardized approach to GI therapies. And I think most importantly, working closely with our patients and our families to understand what some of the real unanswered questions are some of the big important steps. So with that, I'd like to thank you for your time. If you have any questions, you can always direct them to us at pancreas@children's.harvard.edu. I like to say that I'm on Twitter, but I'm really not that good at it. So email is the best. And of course, I'd be happy to take any questions for the next couple minutes. And I thank you for your time.
Thank you, Dr. Grover. That was so informative. I learned something every time. We got a lot
Right.
of questions, of course. This is a popular topic.
So one of the questions that came across was, hasn't it been determined that slow growth is caused by the genetic abnormality?
So there is a role, obviously, that we know that the mutation has issues in terms of bone growth and bone growth overall. So I think that definitely plays a role. But when you think about it, overall, if we're having impaired nutrition and we're not providing the substrate for even the limited bone growth that we have, it's gonna compound and multiply. So trying to optimize as best as we can and get those enzymes in and make sure that they're nutritionally replete. Like I mentioned, the data will say that growth velocity normalizes after that. So whatever you're destined to grow with, at least we want to make it as successful as possible.
Makes sense. Okay, another one is, how can we access the Schwachman diamond charts and use them with our providers?
I think that's a great question. I think you should bring it up with your gastrointestinal doctor. They can very easily look up the literature. It came out. I'm sure the foundation can at least get you the citation or the reference, but they do exist, and you can use that and follow it and just bring it up with your specialist.
Okay. And then I think you might have answered some of this, but how does the parent know when their child's on the proper enzyme dosage?
Yeah, so I mean, for the most part, you're going to see a clinical improvement. You're going to see an improvement in their stooling pattern. You're not going to see the oily stools anymore. You're going to see some sense of normality. And also, you'll see improvement in their growth parameters. Some kids who are on enzymes or who aren't on their proper enzymes can also have other types of GI symptoms. They can have some bloating, they can have some gas because those foods that they're not able to digest get acted upon by the bacteria in their gut, and they oftentimes have looser poops or gas or bloating, and you may actually see a clinical change. I think it's a combination of working with your GI doc and your dietitian. So, say for example, you have low levels of certain fat soluble enzymes, but now that we're able to absorb fat because we're taking our enzymes now, our fat soluble vitamin levels will start to normalize, and you'll feel that symptomatically they're doing a whole lot better, but you'll know it's not working if you're still having the oily output, you're still having the loose diarrheal stools, you're still seeing the oil droplets, and so you'll be able to see.
Okay. And then another one is, what if pancreatic testing is normal, but hold on, it keeps moving, but the patient still has low soluble vitamin levels?
So that may mean, so there are different tests that you can also do to look at absorption. So you could simply try and up the dose and work with your dietitian to make sure you're getting the right enzymes, or you're getting the right dose of your 8x. But then if you're still having signs of malabsorption despite being on the right dose of your enzymes and everything else, then it prompts the question, why are you not absorbing these enzymes, or why are you not absorbing your fat soluble vitamin levels? And then that comes into the question of, okay, so are there other things going on? Do we have to look at the absorptive capability? Do they need a scope? Could they have celiac disease? Could there be another reason for them to not be absorbing?
Makes sense. And then one more, because I know we're keeping you. Are probiotics helpful?
I think probiotics are great. I think probiotics restore and provide good gut health. There are some probiotics that have been studied, not in the setting of Schwachman. This is another great study that I would love to undertake at some point. But in cases where you have bacterial overgrowth, or you have scenarios where you've been on multiple courses of antibiotics, say for fever neutropenia workups or rule outs, this affects the GI tract. This affects the flora of the GI tract. So I personally think probiotics are good. I haven't seen any literature to negate this in the setting of the Schwachman population. I'm sure it's a controversial topic. Um, And I think it's something that you should do in conjunction with your specialist.
I said there was one more and I lied. I'm going to ask you one more. So for the adults with SDS, how do the adults locate GIs, as they're sometimes told by certain GIs that based on serum test and negative PERT that they could not have SDS? I'm going to put that on the thing because I read that wrong.
Adult GIs are sometimes told by BD cert GIs. I don't know what that means.
I don't know either.
So I guess what the question is asking is, how do we find adult gastroenterologists? I think that's tough. I think that's why I became a pediatrician, and I can't hide behind that. Um, the truth is, you want to make sure that there's an adult gastroenterologist who at least will listen to you and think about you. And if they feel that it's out of their scope, then I also think there's no harm in reaching out to a hematologist, because remember that the hematologic aspect of this is something that's going to be following you. And they might say, well, why are you having neutropenia, unexplained neutropenia? They may be able to help you at least work with someone who they've worked with. If this provider happens to be in, the Boston or the New England area, I'm happy to try and connect you with some adult gastroenterologists that I think would be helpful. But I think these are things that would be great going forward. And I'm not saying that this is something that we have to do today, but I think having a database, or at least a list of national providers, both adult and pediatric, who manage Schwachman, would be great for something for the foundation to have on a website, so that patients in different parts of the country can at least know that there's a point person there. We've done a similar model in the National Pancreas Foundation, who I'm also involved with because of my work in pancreatic disease. We know where there are pancreas centers and across the country and so forth that are uh, I won't say endorsed, but at least recognized by the Pancreas Foundation. And maybe this is something that we, as the Schwachman Foundation, can also put together to think about, unique providers both for the pediatric and the adult side, to have points of contact across the country that would be helpful to families.
That'd be great.
Can y'all hear me?
We can.
Okay, good. I'm frozen on my side, but Orva says I'm not frozen. I
You're
have two quick questions for you, Dr. Grover. The first one is, my son has microcephaly. Actually, he just outgrew it barely. But how common is that in the SDS population?
How common is microcephaly? That's a great question, Nicole. I'm trying to think about my panel. I don't know if it's actually been reported in the literature, and I'm trying to think about what I've come across. I can give you a straight up answer, is that I don't know how common it is. It's something that I think we should look at further, and I'm happy to talk to you offline and kind of look at what I've seen in the literature and speak with some colleagues. I can't say that I've seen it that often, but again, Schwachman is also something that we all don't see that often,
Yeah.
and I think that's the whole reason that we have these meetings and these chats. Microcephaly is something that, if this is something that more and more patients are telling us they're seeing and being diagnosed with, then I think this is something that we need to focus on. Because if this is a clinical manifestation that people aren't recognizing, well, then this is something that we should be looking out for. So I can't answer your question
Yeah.
in terms of the frequency or how common it is, but I think it's something that if other families are seeing this as well, then I think this is something we need to bring to light and think about more.
Yeah, thank you. My second question was, so like most of the other families, my son has feeding issues, and it was last year that a dentist, a lot of occupational therapists and other doctors have mentioned he has a low tone tongue. And last year, a dentist asked, does it take a very long time to chew and whatnot? And she really brought to light, and then we got a feeding therapist after that, how hard it was for him to eat because of his tongue. And we've done multiple times a week feeding therapy and all these tongue exercises, and it really has helped. But I don't hear that talked about a lot, about the tongue and the tone. And do you hear that a lot? That the
I do, and I think
yeah,
so. This is where I brought up the idea of the multidisciplinary feeding approach. Like, you have to
yeah,
remember that the kids, even without Schwachman, have issues with poor oropharyngeal muscles. They get tired. These are the kids who, when they were babies, maybe weren't nursing as long or taking the bottle as long because they were tiring,
So tiring.
and so I think having access to a feeding specialist is so instrumental. Kids pocket food in their mouth because they're just too tired from chewing. You know what I mean? Kids have textural
Yeah, my
issues
son
with
does
their
that.
tongue. Yeah, so they'll just sit there and they'll
Yeah.
hold it, and you're like, why aren't you chewing? And you think they don't like your food, but they're tired. It's a lot of work. And so
Yeah.
working with a feeding therapist is something that I routinely involve. We're lucky here, obviously in Boston. Our feeding program is excellent, and we actually have a feeding school where kids can go to of different age groups to help with aversions and exercises to help with feeding and feeding therapies. Um, but it's not always just about what you're giving them. It's a whole lot. It's a whole
It's a
lot, and
lot.
even at early ages, you know, a child who's growing and developing is trying to learn. An infant is trying to learn how to breathe and swallow and
Mhm.
chew and suck and all these things that are happening. And if they have low tone to begin with, that's going to affect how they swallow. It
Mhm.
may mean they're at risk for aspirating. So these are reasons that we always have to be thinking about feeding issues, oral involvement, how their chewing is there bad dentition, are they in pain? So these are all the things that I think about.
So interesting. My son started in-person kindergarten this week, and one of our main reasons for doing that was for feeding, because he was never allowed to be in group feeding therapy because he had so many food allergies. So with
Yeah.
COVID, they're all spread out, and everything's so sanitized.
You bring up allergies, and I think allergies are a whole other area
Mhm.
that I think are interesting in this population. And I think it's another area that we really need to be thinking about, and maybe even considering involving a pediatric allergist to think about, are there certain allergic predispositions that exist, and maybe there are different manifestations
Yeah.
of allergy. As I'm sure you've heard, things like eosinophilic esophagitis is
Mhm.
something that we see a lot in kids. um, it's just no one's looked at it in this
Yeah.
population, and I think allergy is a very, very interesting topic, just like I think liver is as
Yeah,
well.
I agree. My son is pretty extreme, but he's only been in school for 5 days, and he's eating his dinner mostly on his own, and he's eating a good portion of his lunch. So that's 5 days in person. So anyone that's really struggling with their kids, being around other kids and being motivated to eat was massive for my
It's
son.
huge.
So
Completely agree with that.
yeah,
And
so
there are other things, and you know maybe if Catherine has time to address this. Catherine is also our nutritionist who are going to be meeting. She's also part of our program here called the Growth and Nutrition Program. And so these are kids who have feeding issues, not only in regards to the oral aspect, but these are kids who have issues in terms of just their nutrition. And there's this whole spectrum of of growth and nutrition and feeding and avoidant behaviors and things like ARFID syndrome and allergies and so many things that you can't just attribute to say, well, they don't like food or they're not absorbing their food. it's
yeah,
it's more than that. It really is more than that. It's
all the
not just.
anxiety too,
And the
like
pressure and the
pressure.
stress, and
Yes.
then the cultural issues. I mean, if you're trying to, like, for so many cultures, food is such a big
Hmm.
portion. And then the stress when a child isn't eating or wanting to eat, or if the stress that it puts on a family or a grandparent or a sibling or something, it just brings so much anxiety on a child, and they don't know. and
They
and
don't
then it
know.
makes them
No.
feel like they're failing, and it's heartbreaking. So I think working closely with people who have this understanding and
Hmm.
realizing it's not just an issue of enzymes and pancreas, that there are so many overlays, which is
Yeah.
why my very first slide was talking about it's more than just the subspecialty care. There's a lot going on here.
Orva and I both messaged each other and said that's our favorite slide. I've seen you. I think this is my fourth time I've heard this like similar presentation, and I've seen that slide, and it's so powerful because it's so complicated. It's so many different
It's
things.
I think people, and we're all like this, to kind of streamline and make things easier in our life. We try to put things in boxes that we can treat, but I think when you have something that's just so encompassing, you have to look at it from the big picture. You have to kind of look and realize that, you know I can give the kid the enzymes. Great. I can see you for that half-hour visit, and I can tell you what enzymes you should be on, and I can tell you how to poop, and I can think about ways to adjust your acid medicine. But that doesn't change what happens when you go to school and you're sitting at the table and other kids are having food and it hurts your mouth to feed and you feel stressed out about it, and so many things are happening.
Thank you for getting that. Truly, thank you for getting that about all of us. Well, we're about out of time. We want to thank you so much, Dr. Grover, for your time. We're really excited for next week. We're going to be talking to your hepatologist and your dietitian that you work closely with. Thank you again for your time, Dr. Grover, and we'll see you hopefully at camp. Hopefully.
When we have camp, I would love to be there.
I know. We really all missed camp. Like I said, we have an upcoming show next week with hepatologist and dietitian you work closely with. I think that show is going to be really popular because we all have a lot of feeding questions.
Don't be too hard on them. This is their first time.
Okay. I also want to say, if you're not on the SDS registry, I want to mention this every show. Please get on the SDS registry. It's different than Be the Match and the Neutropenia registry and the bone marrow failure registry. We are really stronger together, and that's how we can get this longitudinal data. So if you have any questions, message us at the show, and we can get you in contact with the registry. Thank you to all the behind the scenes people that help us. Esther Jones, Stephanie Orva, normally is behind the scenes, but she jumped in front of the camera today. Thank you. And I want to remind you of our awesome giveaway today, which is so appropriate. Everyone poops. How many copies do you have of this, Dr. Gerber? Like, just like a waiting table?
Oh, listen, if I were to show you the other things I have in my office right now,
I can't even imagine.
I mean, I have this on my pen.
This is so popular right now.
It's like I have a turd on my pencil. So I have that. I have the guide to farts. It's my farting book. I have lots of poop paraphernalia. That's why they call me Dr. Poo and Spew.
I love it. So you
I know we
could
have
win this book.
Sorry, go ahead.
I was going to say, you could win this book by liking, commenting, sharing, starting the watch party, interacting with this show in any way. I'm sorry, Orva, what were we going to say?
There's quite a few questions that we didn't get to. I'm going to go ahead and forward them to you, and then if you could just get back to them, and I could share them with the group.
That's great.
All right, guys.
Thank you, guys. Everyone stay safe. I hope all the kids are enjoying getting back to school, whether it's virtual or face-to-face. And again, thank you, Dr. Gerber. We really appreciate you.
Anytime, guys. It was lovely to see you.
Bye.
Thank you, Orva. Bye-bye.